Body packer syndrome. Although this is more commonly associated with the smuggling of cocaine, it has also been reported in the case of drugs such as heroin, amphetamine, and cannabis. Body packer or mule is an individual who attempts to transport illicit drug from one country to another by ingesting wrapped packages or condoms or balloons containing concentrated drug, especially cocaine or heroin. Next is body stuffers, also known as contact precipitated concealers, constitute a different entity referred to those individuals who rapidly ingest illegal drug to avoid detection or arrest, often using flimsy wrapping, cling film tape, or a single layer cellophane bag. The term parachuting is used when the intent is to purposefully delay absorption. There is often early leakage of drugs from the package, generally within 8 hours of injection. Body package often ingest a drug to slow gastric motility, loperamide, which may increase chances of bowel obstruction, as opiates by themselves slow GI motility. After arrival at the destination, cathartic are administered and the packets are defecated out. Sometimes rectal suppositories or disposable enemas are used, although generally asymptomatic. In a few cases, serious toxicity may result due to rupture of packet. Packages are congested in stomach or duodenum, carrying a high risk of rupture due to the action of a gastric acid on the packaging. Death due to intestinal obstruction and perforation has been reported in body package. Diagnosis of an asymptomatic body packer can be accomplished with an abdominal X-ray. Ultrasound or computer tomography CT scan. The last two methods should be resorted only if X-ray is unclear. In some cases, fecal examination over a period of few days may be necessary. It is possible too that a female patient is pregnant. This should be excluded by urine testing before a CT scan is performed. If a pregnant patient, consider ultrasound or magnetic resonance imaging through MR does not visualize packets because of the lack of protons. The drug carried by drug bags are generally packed in four ways. Type 1, loosely packed powder in 2 to 4 layers of wrapping, condom, latex, gloves, and balloons. This may be identified on plain X-ray as a circular white density. They are at risk of rupture and highly hazardous. Type 2, tightly packaged powder covered by 7 layers of tied tubular latex. These are less susceptible to breakage. They may be visible on X-rays as soft tissue densities with the surrounding gas halos. Type 3, hardened drug, usually cocaine paste, may be wrapped in aluminum foil and overwrapped with 3 to 5 layers of a tubular latex. These are least likely to break, may be difficult to detect on X-ray. Type 4, hardened drug, usually cocaine paste, machine packaged in a tubular latex and coated in a layer of colored paraffin fiber dust. Packages are uniform shape and size, radio opaque and easily identified by X-ray. This kind of packaging carries a low risk of rupture. Asymptomatic patients should be treated by whole bowel irrigation with a polyethylene glycol solution. Or some investigators do not approve this method since the polyethylene glycol can dissolve in the heroin from a packet, rupturing it and increasing absorption of poison. Instead, a period of waiting is recommended so that all packages pass into the colon from the stomach. Then low volume phosphorus soda enemas or high volume saline enemas are administered. Food ingestion must not be permitted until all packages are moved into the colon. Metoclopramide 10 mg 8 hourly may be administered to encourage gastric emptying. Bowel obstruction must be ruled out. It may be advisable to empty the stomach first by biscodile suppository. Surgical intervention for bowel obstruction is necessary in 3 to 5% of body package. Body packets remain at a severe intoxication until complete evacuation of all package, usually indicated by passage of 2 consecutive package-free stools. Repeated radiology CT may be necessary for the confirmation of evacuation in some cases. Example, when patients exhibit intoxication even after stools remain packaging free. Symptomatic patients must be managed with a continuous infusion naloxone, activated charcoal, and whole bowel irrigation. If respiratory failure or pulmonary edema occurs despite naloxone, consider intubation, mechanical ventilation, surgical removal, intestinal perforation or obstruction by packets requires surgical intervention. Whenever possible, a CT scan without oral contact should be performed prior to operative intervention. But this should not be allowed to delay surgical intervention. Intact packets in the distal bowel should be manually expelled through the anal canal. Intact packets located in the proximal small bowel should be milked retrogradely into the stomach where they can be removed by single gastrotomy. Milking ruptured packet may risk of increased drug absorption. Multiple enterotomies may therefore be avoidable. Packages are widely dispersed throughout the intestine. If multiple enterotomies are required, the surgeon should consider delayed wound closure to prevent infection. Thank you.